Inside this video right here, I'm going to talk about the 4 types of shock that you need to know. Now, first we have cardiogenic shock. So the way to remember cardiogenic is it has cardio in it. We think of cardio, we think of the heart. It's the heart's fault. In this case, what is causing the shock is a heart problem. It's either an MI or it's heart failure. So what's happened is the MI, the heart attack, or the heart failure is so bad, we've now entered shock, okay? Which is next step is death, okay? So this is cardiogenic shock. It's the heart's fault this all happened. It's a heart problem. Now, obstructive. Obstructive shock, what does it do with, is something in the body that's stopping the normal pattern of blood flow. What does that mean? Pulmonary embolism. Okay. Could be a pneumothorax. So let me give you an example of obstructive shock with pneumothorax. A tension pneumothorax will put pressure so far that it actually stops the heart as a pump. So we get heart failure, not because the heart did anything wrong. That's cardiogenic shock. Because we have a pneumothorax, the heart is now failing as a pump. That's why we get JVD. That's why we get tracheal deviation with tension pneumothorax. Obstructive shock. So flow has stopped. There's an issue going on, but not the heart's problem, something else. There it is. Now, distributive. Distributive shock is the one you got to remember. There's 4 types of shock: cardiogenic, obstructive, distributive, and hypovolemic. But there's 3 subtypes in one of them, and it's this one, distributive. So you got to remember that. Distributive has 3 subtypes. Here they are. And I think this is where everyone gets confused. So look, we have sepsis, neurogenic, and anaphylaxis, okay? Now, with these 3 types of shock, you have to remember, these are the 3 types of shock that ultimately are going to need vasopressors. Now, why is that? Why do we need vasopressors much more in this type of shock versus this type? Okay, hear me out here. When your body becomes septic, anaphylactic, or neurogenic, instead of your body fighting back by clamping down and vasoconstricting, which will try to keep your blood pressure up, that happens in hypovolemic. In distributive shock, it just goes like this. You enter shock, you vasodilate abnormally. So your blood pressure goes way down. So you're not 80/60 or 80/70, you're trying to fight back. You're like 80/30, 80/40 with these type of shocks. So that's why we talk about pressors for these types. Okay? Remember this, this is the big thing to remember, that abnormal vasodilation. And finally, I call it classic shock. Me personally, maybe you too, when I think of shock, the first thing I think about is a stabbing or a shooting and someone going into shock. Hypovolemic. Now, it's not just that, though. You could also be, we talk about fluid, major fluid loss like dehydration pathway can ultimately cause hypovolemia. So think trauma and think fluid loss. That's hypovolemia. So now you got them both covered in case you see it out there, okay? So these are your 4 types of shocks. Our goal in EMS, if we find somebody in shock, start to treat it. If we find somebody on the way to shock, we want to stabilize them so they don't end up there. That's EMS. We can find these life threats. See you next time. Today we're going to talk about 3 things about OBGYN emergencies. Now, these are the 3 things that I find trips up students. So let's tackle them today so we know it cold. Now here we go. Now, notice the first thing I've done. We have 2 emergencies down here. We have 1 emergency up here. So the first thing we got to know is these 2 emergencies that have to do with the placenta, they occur in the 3rd trimester, where ectopic pregnancy occurs in the 1st. Okay? So if we know that, just that alone, before I even tell you what these are, if you have somebody with a 1st trimester emergency, well, what could it be? It could be a spontaneous abortion. It could be a ectopic. Right. What if it's third trimester? Well, it's not this. We're going to talk about it. It's got to be one of these. There could be others, but it could be one of these. So let's tackle these 3 emergencies right now, okay? Now, ectopic pregnancy is when you have the ovum, okay? It's supposed to go in the uterus, and that's where the baby grows. The difference here is what happens. It doesn't make it to the uterus. It could usually, I find, in the fallopian tube, but it could be anywhere, but it's not in the uterus. Okay, that's the definition of it. Now, imagine this. Imagine you have the ovum growing in the fallopian tube, which is a small, tiny tube that cannot handle a baby. So what do you think is going to happen? A massive hemorrhage, abdominal pain. Well, I said hemorrhage. You're going to get bleeding. There it is. These are your signs and symptoms. Abdominal pain and bleeding. Okay. Well, now, when does it usually happen? I already told you. First trimester. So, it's not a rule, but usually, I put a star there, usually 2 to 12 weeks is when it's going to be. All right? So now, down here, and everyone knows this who's going through class, these are the words that nobody can say, but you have to remember. So, watch what I'm going to do here. It's very powerful. Very simply, the placenta is basically the nutrient storage, if you will, for the baby. Okay? So the baby needs the mother, and the baby needs the placenta. All right? So we're going along, 3rd trimester. The placenta decides to make a move. The placenta decides to move abruptly. Okay. There's your abruptio, right there. What's the definition? The placenta detaches too early, either partially or fully. That's why we call it abrupt. So instead of trying to say this, I want you to change. You know what it's going to look like on the test. You know what it is. But I want you to change it to, we have an abrupt placenta. So now you understand what it means. Okay? The placenta decides, you know what? I'm out of here. I'm going to detach early. We got an abrupt placenta. You see? Now we made it easy. Now let's do the same thing with placenta previa. Okay, placenta, okay, previa. Okay, let's change previa to previous. Okay, and that might work. Let's try. Well, placenta previa is when we have the placenta covering up the cervical opening. The baby's got to go through the opening. So the placenta decides, you know what? I'm not going to go where I'm supposed to go, kind of on the side. I'm going to go right over the opening, again, either partially or fully blocking the opening. Now, if you think about it, okay, this isn't a rule, but think about it. If that baby was to deliver, the placenta's in the way. So you can say it would come first, you see? So placenta previous, it goes first. That's how you remember it, okay? So instead of saying previa, we're going to say placenta previous. The placenta wants to go first, so it's covering up the opening the baby has to go through. And my friends, you just tackled 3 OBGYN emergencies with me right here. Pretty cool? I'll see you in the next video. The mnemonic I have for you to remember this, I got a few different ones here we're going to go over and little tricks to remember it. But the trick I want you to remember, I'm taking the sympathetic and the parasympathetic, and I'm going to basically make it into a world of extremes. So I want you to think of the sympathetic nervous system like a guy on cocaine. I want you to think of the parasympathetic nervous system like the same guy, but now he's on heroin. So 2 different situations. One day he's on cocaine, one day he's on heroin. You already know, most lay people already know, what cocaine does and what heroin does. But now we have to get a little more particular because we're going to be a health professional. And we're going to do that now, okay? So check this out. They call sympathetic nervous system the fight or flight. Think about that man in cocaine. He's moving around. He's not relaxing. He's moving around. That will give you the idea to say, okay, that means maybe his heart rate goes up. You're on, you're on the right track. We're almost there. Now, parasympathetic man over here, we say, that's heroin. Okay. Well, someone on heroin, are they moving around? No. They're resting and digesting. Okay? So they call us the rest and digest. Now, look, this is the particulars. Here are the eyes. So with the eyes here, if you are in a fight or flight mode, do you want your eyes to be constricted, you can't see anything, or you want to be dilated and open so you can see? I want them open. Do you want your heart rate to go up? Would it go up if you were in a fight or flight scenario? Yeah, you would. It would go up. Okay, heart makes sense. The lungs, you want them to be dilated because you're going to be fighting or in a flight. And remember the cocaine analogy, the heart rate's going up. You see where I'm going here? It's all kind of piecing together. And the stomach, well, again, this is not a rule, okay? But just to give you an idea, ever drink coffee? You're not very hungry. It gives you that up feeling, like the sympathetic nervous system gives you the up feeling, like cocaine gives you an up feeling. You're not very hungry. You see the parallels between the two? This is what I'm trying to hit home for you so you can remember this versus this. Now check this out. Eyes, they constrict. Every single patient that we see on heroin has pinpoint pupils. Parasympathetic also constricts. You see? Check this out. Heart goes down. Wait, doesn't it happen in a heroin patient? It does. You see? Lungs, they can constrict. Now you're not going to have an asthma attack constriction, but they're not going to be dilated, okay? So I put the little asterisk there just so you know. You're not going to have an asthma attack, okay? You're going to be a little more constricted, okay? The stomach, rest and digest. You're going to stimulate your digestion because you're resting and digesting with heroin man. You see? Over here, you're going on a run with cocaine man. Cocaine man, heroin man. Sympathetic, parasympathetic. You go up, you go down. I got to see better. I'm resting right now. Leave me alone. I don't got to see anything because I'm relaxing right now. You get it? Okay. This is it. You got to know this for EMS because you're going to see this a lot with your patients when they're in one of these different systems. You got to know this cold. Now you do. If you need more help, I want you to replay this video again and again until you get it. Good job. Today we're talking about Stridor. So when a lot of people think about Stridor, what I find when I talk with students is they go right to pediatrics, which is great. But adults can have Stridor too. And in this video, I'm going to show you how to remember the main, more acute types of Stridor so you got it down cold. You ready? Here we go. Now, I want you to start with foreign body airway obstruction. The reason for that is it's pretty obvious, if somebody is choking, right? And you hear Stridor. So that's an easy one to knock out. It doesn't take much history, it doesn't take much exam to figure that out. So if you hear Stridor, the first thing I want you to do is check for a foreign body airway obstruction. If it's not that, we move on. Now, are you dealing with a pediatric patient or an adult patient? If we're dealing with a pediatric, I want you to move to here. See, I have 1, you start here, P for pediatric, and then you have AB, okay? AB, we'll get to it. A for adult to remember, AB, okay? So croup and epiglottitis are just more common in kids. That's it. They're more common in kids. Croup is a disease for children. Epiglottitis could happen to anybody. But again, it's more common in pediatrics. So we start there with our assessments. So how do we differentiate croup versus epiglottitis if they both have Stridor? Well, here it is. Croup, there is no drooling, and the patient will have a bark-like cough, loud. On the opposite end, epiglottitis is more acute, where it might wake them out of their sleep, where croup could be a little bit of a slower onset. The other thing with epiglottitis is they cannot swallow, so they are drooling, so there's no cough. I'll say it again. Epiglottitis, they are drooling because they cannot swallow, and there's no cough for that reason. You see? But they have stridor. Okay. Now, if we don't have a pediatric patient, okay, we can check for this, but I recommend you go here first because it's just more common. Last two, the AB is anaphylaxis and burns. Anaphylaxis and burns. So, if we have an inhalation injury, that's burns. Anaphylaxis is 2 or more body systems being affected by an allergen. So we'll have hives and nausea, vomiting, anaphylaxis. Wheezing, stridor, hives, you name it, anaphylaxis. 2 or more body systems. Hives by itself, allergic reaction. But remember, this patient has stridor. So these right here are the 5 causes of stridor. So when you go to your patient, here's how I want you to remember it. Let's go over it again. You see a patient in front of you. First thing we're going to do, the easy one. Check for a foreign body airway obstruction. Positive or negative? Negative, move on. Is it a child? Okay. Check for signs of croup. Check for signs of epiglottitis. Positive or negative? Let's say in the child, they're both negative. Now we'll move on to anaphylaxis and burns. Assess that. An adult patient, we flip the script. We're going to go foreign body airway. Now check for the more common anaphylaxis and burns. And then we're going to check for a possible epiglottitis in an adult. There it is. Hope it helps out your assessment. These are your 5. Remember, 1 P and your AB, your A is for adult. One of my core mnemonics is A.A.C. Asthma, COPD, anaphylaxis. It has to do with a patient when you walk up, listen to lung sounds, and they have wheezing. Think A.A.C. But in this video, I want to talk more about asthma, more about COPD, and more about anaphylaxis. So let's start first with the first A in this mnemonic, which is asthma. So there's another reason as well why this mnemonic, I believe, works so well. This right here, honestly, is some of the most common calls that we get in EMS. So it's good to remember. Now, asthma. The asthma patient, one of the most important questions to ask somebody with asthma is this. Have you ever been intubated before? And then if they answer yes, when was the last time that you were intubated? Have you ever gone to the ICU before for your asthma, right? So why do we ask that question? Well, the reason why we ask that question is usually, it's not a rule, but usually asthma will go on the same course, meaning if someone has an asthma attack, they usually have similar symptoms and similar style of flare-up when it happens. So meaning, ever hear of like a good diabetic and a bad diabetic? Where in a diabetic, it's, they just drop real low with their blood sugar and they have the same pattern. I find it's very similar also with asthma patients. So you want to ask that. It's going to gauge, it's not a rule, but it usually is a gauge of how severe this could be, okay, with the asthma attack, okay? Or moreover, how fast are they going to decomp, okay? Quick tip for you, I think it will be very helpful. The doctor in hospital, or whoever you're transferring care to, a nurse, practitioner, whatever it is, they're going to be very thankful that you got that information. So that's asthma tip number 1. Now, obviously with asthma, what are we focusing on with that patient? We're focusing on getting their SpO2 over 94%. We're focusing on the asthma patient on opening up their lungs with bronchodilators. So obviously continuous nebs, right? We know our steroid of choice is going to be Ciamedrol at the IV, okay? That's more for the long-term effect. Then obviously we have 2 players. How many? 2 players on the bench waiting to be brought in for severe asthma. First we got epi, okay, a shot of epi in the arm, okay? And then the second player that everyone forgets is our friend magnesium, which is a smooth muscle relaxant, okay? Don't forget our friend mag, but it's your last line of defense. You'd hang a mag drip. Okay, remember, mag is measured in grams, okay? Good. Now, next A here we have is anaphylaxis. With anaphylaxis, remember, 2 or more body systems are affected. Wheezing and nausea, anaphylaxis. Hives, nausea, vomiting, anaphylaxis. Stridor, wheezing, nausea, highs, 2 or more, anaphylaxis. The big thing here, remember, is anyone that shows highs, give them some Benadryl, okay? If we have 2 or more body systems, we got to act anaphylaxis and be aggressive with your treatment. We don't wait till they're in shock and start giving them epi and stuff like that. We treat aggressively early on. That's your anaphylaxis, okay? So what are some of the most common things people get allergic to? Medications, okay? Ask them, did you take any new medications recently? Food. Remember that sample, that last oral intake? There it is, okay? And then the other thing you want to think about is what I call basically insects, okay? So it could be a bite of some sort. So medications, food, and bites. There it is. Now lastly, we have COPD. Now COPD is broken up into 2. I put it at the end for a reason too. I want to remind you of me. COPD is broken up into 2 different branches. Okay, I'm not going to draw it all out here. I'm going to show you in voice. But remember, when you think COPD, draw out 2 branches. Okay, so the first branch is chronic bronchitis. Chronic bronchitis. Let's break it down. Chronic over 3 months. It's a long time. Okay. Bronchitis. We know the bronchioles are in the lungs. Anything with an itis is infection or properly inflammation of it. Okay? So, if we think about it, hepatitis, inflammation or infection of liver, right? In this case, remember the bronchioles. So it's a chronic inflammation or infected bronchiole. Okay? In this case, inflammation. Okay? So this patient is probably going to be on an oral steroid at home, and as it gets worse, they're going to be on supplemental oxygen. The main key difference between branch 1, chronic bronchitis, branch number 2, emphysema. Emphysema is like puzzle pieces. Evan, what do you mean puzzle pieces? Let me explain. I think of the alveoli. So if I was to draw an alveoli out like this, okay? Here, let's say it's an alveoli, okay? That's a normal one, okay? You know when you have a puzzle and it's all put together? That's a healthy alveoli. Perfect. Ever have someone come up and start plucking puzzle pieces away from the puzzle and now there's holes in it? That's what the alveoli looks like in emphysema, okay? Essentially, we have puzzle pieces missing. That's the way I remember it, from the alveoli. What this means at the core level is this. The alveoli is basically being under attack. It's being destructed, okay? There's holes. There's changes in the alveoli. It's not a healthy alveoli like it should be. So gas exchange, oxygen, carbon dioxide is tampered with in your patient. So it's not a bronchial issue. It's an alveoli and gas exchange issue, okay? Chronic bronchitis is an inflammation issue, okay? And that is the 2 wings of COPD. Now, how do we treat that? Obviously, we want to open the lungs. If we open the lungs up, that's going to help a lot. And one quick thing about COPD before I go, I want to leave you with this. COPD is like diabetics. If you ask a diabetic, what's the normal blood glucose for you? When you're working with a COPD patient, and that's your patient, you say, what's the normal pulse ox? What's the normal SpO2 for you? What's your normal oxygen level? They will tell you that. Then gauge what they're at. If they're lower than that, get them back to their normal. It's a specialty patient. My friends, I'll see you tomorrow. Inside this video right here, we're going to be talking about altered mental status. Now, you're going to want to stay to the end of this video, and here's why. I'm going to give you my exact approach from the beginning to the end of my approach with somebody who maybe has a GCS of 14, 13, when it should be 15. Maybe they have a new onset of confusion. They're an altered mental status patient, but they're still awake. Here's the first board here. Stay tuned to the end. I'm going to finish it with a second one. Now, the first mnemonic as I approach the patient is this. There is 4 S's in altered mental status. How many? 4. How many? There's 4. So there's 4 S's. We start with the S's, and they're in a certain order, and I'll explain why. The first S is blood sugar. Check a blood sugar, a blood glucose level on your patient. So as I approach that patient, with maybe a GCS of 13 today, confused, right? Not obeying commands, but alert. First thing we're going to do is we're going to obviously get vital signs, okay? But while we're doing that, we're going to get a blood sugar on our patient, right? And that leads us to number 2. Number 2 is stroke. No stroke is a stroke until you get a blood sugar level, blood glucose. You've already gotten that. So now you can move into your stroke, your fast exam, okay? Your face, your arm drift, your speech, your time. Now there's 2 more S's left. Now in no particular order here, we have sepsis and seizure patients. So check a med list. Is there Keppra? Is there Lamictal? Is there Dilantin? Right? Is there Tegretol? Right? Medications for treating seizure patients. Now, finally, sepsis. 2 main pathways I commonly see in sepsis. Okay? Pneumonia, UTI. Now, I'm going to throw a curveball at you with sepsis. Remember this. Just talking about this with my inner circle students is, remember, if anything inside of here, our abdomen, abdominal pain, we have a hard, rigid abdomen, right? Maybe a late sign distension. If we inflame our abdominal cavity because something leaked out of it, could be a trauma, could be appendicitis, that's going to cause sepsis. Don't forget that. Those are the ones to watch out for. There's others, but those are the ones to check for first. Okay? So there's 4 S's. Now, what if we assess our patient, blood sugar is normal, stroke, no signs. Sepsis, no signs. Seizure, no signs. No blood in the mouth, no bite in their tongue. They're not postictal. No one saw an event like that. What do we do? If it's not NOT, if it's not one of the 4 S's, the mnemonic is not. Are we at a sneaky overdose? So the N is Narcan. Narcan makes you think of an overdose, right? So are we at a sneaky overdose of anything? Check pill bottles. Check patient vitals, right? Did he or she take something accidentally or on purpose? So N is for Narcan, but really, are we at a sneaky overdose of anything? O is for oxygen. What's your pulse ox reading? What's the SpO2? So T for trauma is, it could be any trauma, but I like to think as far as altered mental, head trauma. So take the patient's hat off. Is there some sort of sneaky trauma, like a hematoma you're not seeing here, that you missed in your exam? Pupil exam. Look out for sneaky trauma that's going to cause altered mentation. Now, I'm going to do board number 2 here on the whiteboard, and we're going to wrap this up. Now, let's say you go through your 4 S's and your NOT. Everything's negative. You did your vitals already, and you can't find anything there. Nothing else on physical exam, but they're altered and you don't know why. Well, obviously by this point, we've already been transporting the patient prior. By this point, we're going to the hospital, okay? And I want you to think about these things. I want you to add 2 more E's. My name's Evan. There's an E in that. So to remember, hey, Evan said, add 2 more E's, okay? Electrolytes, environmental. Where was your patient found? Could it be too hot or too cold? Environmental issue, okay? Dehydration, kind of mixing that. And then finally, with electrolytes, I want you to think about this. What is one thing you haven't done yet? That also starts with an E, an EKG. So if it's not the 4 S's, if it's not NOT, think about the letter E. Electrolytes, environmental, or EKG. You might find your EKG is abnormal. Maybe there the problem lies. Maybe you're at a hyperkalemia, right? That could be it, okay? So you'll see here, electrolytes, environmental, continue to do vitals, EKG, guess what? The buck does not stop with us. They're going to the hospital. They're going to see a physician. It might be a Labs. On their labs in hospital, they draw the labs. Up, there's the culprit, and there it is. So my friends, this is how, as a paramedic or as an EMT, as an advanced EMT, you would work up an alternate mental status who maybe is confused, GCS 14, 13, but they're awake, okay? This is one of the most common calls we get. Now you know, step by step, how to tackle it and look sharp, look like a pro. I'll see you tomorrow. This right here is a serious medical emergency, anaphylaxis. Now, in this video, I'm going to talk to you about the difference between allergic reaction and anaphylaxis, and also give you some telltale signs that your patient is in anaphylaxis, whether they're trending towards shock, and we're also going to talk about treatment for the patient. Now, the first thing I want to talk about here is what is the key difference between allergic reaction and anaphylaxis when you're assessing a patient out in the field. So let's say you approach your patient. Let's just say, for example, they were a 35-year-old male patient, for example, okay? You walk up, the patient has hives only. Okay, so you look at the arms, there's hives in the chest, the arms. Okay. Anything else bothering you? Any other complaints? Any other exam findings? No. They are having a simple allergic reaction. An allergic reaction is one body system. Well, what's the body system? Well, the skin's having a reaction. There you go. Okay. Now, two or more body systems affected means they're right now in anaphylaxis. Now, I got to get this out right now before we go any farther. If you have a patient in anaphylaxis, you treat them aggressively. This is not the time to think, oh, let me hold back. You hold back, we're going to talk about that in a second, where they're going to end up. So I remember when I was a new medic, and I was a student medic, I had a call, and my preceptor told me these two things that stuck with me. Two or more body systems, anaphylaxis, and you need to treat aggressively on the call. Now, let's talk about this now. Let's say we have a patient with allergic reaction. Okay, remember, simple allergic reaction, one body system. They call the ambulance. They have hives. They're nervous. What do? Well, transport, give some Benadryl, vital signs, exam. Sounds good to me. Okay? Now, what about anaphylaxis? And what will you notice with anaphylaxis? Here it is. Nausea, vomiting, tachycardia, wheezing, stridor. Essentially, what's going to happen to this patient anaphylaxis is at some point they're going to have extremely poor, or ultimately, it can happen, no air exchange, because the tightening of the airways. Okay? Lower, wheezing, upper, that's the stridor you're hearing. Okay? So this is why we need to treat anaphylaxis way before they go into shock. If they're in shock, we're already too late. We need to get there way before. So as soon as you see two or more body systems, they're getting right here. Okay? Now here's our treatment. So it's pretty much I would say, the order of operations that I like to look at. Because like I told you, if somebody has hives, giving them Benadryl is very, very fair to do, Like I've been a medic out in the field, and let's say you're a medic working out in the field, I've given a patient who had hives, they called the ambulance. Okay, I gave them Benadryl, right? Now, I don't know if you carry PO Benadryl. I don't know if what kind of Benadryl you carry. We all know it can come IM or IV, right? Give him a shot of Benadryl. That could hurt him, okay? Now, other things we look at here, these are all the treatments. Well, the first thing is we want to focus on their SpO2. So what's their pulse oximetry come back as? If they're hypoxic, give oxygen, of course, right? We have the vital signs, okay? The vital signs are going to tell us, are they in shock yet or not? So that tachycardia, that hypotension, shock patient, okay? Now, here's what I want you to look at as the treatment plan. Think about this. We got two drugs that are going to open up the lung fields. Albuterol, epinephrine, axon beta 2, okay? Bronchodilate. That's why we give it in this case. It makes sense, right? Right. Now, what else? Well, nausea vomiting patients, giving Zofran, for example. You may carry other drugs. Zofran are the most common for EMS. So we think about our patient. O2 as needed, obviously, right? Depending on whether they're simple or anaphylaxis. So we're going to give oxygen. Okay. We're probably going to give oxygen with a neb if we're giving a neb, like albuterol. Okay. We have Benadryl. We have epinephrine. We have Zofran, right? So that is what you want to look at here with your patient of anaphylaxis. My number one tip, and remember this, 2 or more body systems, treat aggressively. Anaphylaxis. There it is. A patient that has difficulty breathing is one of the most common calls that we get dispatched to as EMTs, advanced EMTs, and paramedics. Inside this video right here, I'm going to be going over one of my greatest mnemonics. Big shout out to John Belinsky Jr., PA, one of my mentors. And I'm going to go over this mnemonic for you for EMS. Okay? Now here it is. What is in your mindset when you approach a difficulty breathing patient? Now this mnemonic, HORRID, H-O-R-I-D, is this. You don't want to make a horrid mistake and miss something when someone can't breathe. Okay? You don't want to make a horrid mistake and miss something when somebody can't breathe. Okay? So don't make a horrid mistake. As an EMT or a paramedic, our number one goal is to find out life threats. That's our whole purpose. Then we use the tools that we have at our provider level to stabilize those life threats and get the patient to the hospital. That's EMS. HORRID does just that. We got to find out these life threats. So we approach the patient, and we're then going to hit them with HORRID. What I mean by that, we're going to go through the mnemonic. So the first thing I want you to think about is H for heart. Think about their heart. Are they showing signs of a heart attack? Nausea, vomiting, chest pain, difficulty breathing, for example, right? Do they have some atypical symptoms, maybe like general weakness, back pain of STEMI? If you're a medic or an EMT who's clear to do so, do a 12-lead EKG, okay? And what does that EKG tell you? Remember, always do at least 2 EKGs, compare the first and the next one. I usually do 2 or 3 per call, okay? Now, the next one that we're going to talk about here, inside of heart, is CHF. Well, what does CHF look like? Well, it's got bilateral rails. Okay, that's the fluid coming up in the lungs. It's got JVD. It's got high blood pressure, like, 180 over 100, 200 over 100. Okay? What else may it have? Pedal edema increasing, right? And they probably have a history of it. Okay? So that's going to be your CHF. I'll give you one more on that. Remember, the pink frothy sputum, they're coughing up. Okay? That's CHF. So are you seeing anything along the lines of the heart? If it is, check it off. Okay? Now the next one here is going to be O for obstruction. Now with obstruction, what we have basically is stridor. Okay? That stridor could be a foreign body airway and also could be anaphylaxis. Okay? So that's our O, any obstructions going on. Next here we have R for reactive airway. Now reactive airway, this is my very own mnemonic, A.A.C. Hit them with A.A.C. A.A.C. stands for asthma, anaphylaxis, and COPD. Basically, reactive airway is what wheezes. Those wheeze, so evaluate them for that, okay? Now, the next going down from there is I for infection. Obviously, COVID-19, that makes a lot of sense. Also, pneumonia makes a lot of sense. Could be the flu, makes a lot of sense there. Finally, D stands for death, which is pulmonary embolism or pneumothorax. Now, let's go over these two just to make sure we're on the same page here. Pulmonary embolism, okay, you're at risk factor of that if you smoke, if you're on birth control pills, if you're in a long period of stasis, not moving, bed rest, plane rides, train rides, bus rides, right? Recent surgeries, stuff like that, okay? Now, a pulmonary embolism is going to have clear or diminished lung sounds, and they're going to be tachycardic and hypoxic. Again, they can't breathe, okay? That's pulmonary embolism, okay? Now, pneumothorax has to do with unequal lung sounds, okay? One's going to be okay. The other side's going to be not okay. Okay, diminished or absent. Okay. Remember, there could be JVD, tracheal deviation with pneumothorax. And remember, a medical pneumothorax, a spontaneous one, tall, lanky people. Okay, think of like an NBA player. And then pneumothorax, traumatic, they probably had a traumatic event. Don't miss a pneumothorax on a fall patient. Okay? Everyone thinks about car accidents because all that pressure, that force. Don't forget about falls. So my friends, this is exactly what I do and what I teach my students to do as far as evaluating a difficulty breathing patient. Hit them with HORID. If you go through HORID, these are the 5 worst causes of difficulty breathing. Patient with chest pain, it could be so many different things that causes chest pain. In EMS, we gotta watch out for these 5 things to go through each one step by step, okay? Now, big shout out first to John Belinsky Jr., a PA, one of my mentors for this great mnemonic. Is incredible and helped me so much throughout my career. I'm going to share it with you now. But what I'm going to do is break this down a little bit for EMS so we can break it down when we're out in the field. Let's do it. Now, you can see here it's the mnemonic is who's your papa? P-A-P-P-A. Now let's start with pericarditis. Pericarditis, 2 things. If we lean our patient backwards in the stretcher, we bring the stretcher down, okay, when they're on the EMS stretcher, and the pain gets a lot worse. That's a sign of pericarditis. Pericarditis, not a rule, but usually is a more sharp pain. And number 2, let's talk about, is on EKG. Remember, we talk about pericarditis and EKG. It's ST elevation all over the place. And the PR interval is going to be depressed. Okay? So look out for that PR depression and look out for that smiling upstroke. Okay? An elevation that just is all over the place and doesn't make sense. It's not 2 up and 2 down. It's just elevated, no reciprocal changes. It's all over the place and it's got PR depression with a smiling upstroke. Now, ACS. Fancy word, right? Acute coronary syndrome. What does that mean? There's a coronary artery in your heart that is currently being under attack right now. Okay? STEMI. ST elevation myocardial infarction. There's an EKG that patient has that shows ST elevation, which is a sign of a myocardial infarction, and it's positive for that. STEMI. That's all it means. Your patient's having a heart attack, okay? Now, we have classic signs and atypical signs. Classic sign, crushing chest pain, left-sided into my jaw, down my arm. It happened out of nowhere. Happened while I was shoveling. Happened, winter's coming up. Happened while I was mowing the lawn. Happened while I was running out of nowhere, right? Classic. Difficulty breathing. Not so classic. You know, I'm so weak that I couldn't even get out of bed. Someone who's general weakness, they can't get out of bed, they're having a hard time speaking, they're short of breath, they have chest pain, they're nauseous, they're vomiting, back pain. That's going to be atypical. Let's talk now about pulmonary embolism. Who's at risk? Smoking, birth control, pregnancy, long plane rides, train rides, right? Could be a long bus ride, right? Any long period of bed rest, stasis, not moving, right? Vascular surgery, cancer drugs can increase this stuff, right? If you see it on a med list, for example. So pulmonary embolism, what that is a blockage of your pulmonary arteries, okay? It's being clogged up. Usually starts by having a DVT. So remember, our DVT, think about it. There's a clot there, okay? Deep vein thrombosis. Okay, there's a clot in our calf. A little piece breaks off. We know veins, if you watch my heart blood flow video, veins go towards the heart. The venous system goes towards the heart. So if we go towards the heart, we hit the right atrium, then the right ventricle, and then we pipe right in to the pulmonary artery, where the clot lodges. And what is your patient going to look like? Your patient is going to have bilaterally clear lung sounds or bilaterally diminished lung sounds. They're going to be very short of breath with tachycardia, a high heart rate, and pulse oximetry will be very low. Okay, that's a telltale sign there. Pneumothorax. We have a medical pneumothorax and a traumatic pneumothorax. So a medical pneumothorax, like a spontaneous pneumo, there's no trauma involved. Think of a really skinny, tall, lanky person, kind of maybe like an NBA player, for example. That would be an example of somebody who has a medical spontaneous pneumothorax. They just get them all the time, okay? Now, a tension pneumothorax, like the one we may see in a trauma patient, what's happening is, if I get shot over here on this side, on the right side of my chest, what's going to happen is the pressure is going to increase and increase and increase and increase and increase until that this lung on the right side is collapsed and it's starting to move over. Here's our mediastinum in the middle, okay? Good way to remember that. And it's moving, it's putting pressure on the heart. So the heart fails the pump. You get JVD. You get tracheal deviation. You get clear on one side, maybe for a little while, and then you have a diminished on the side that's affected, right? So that's what we're talking about here with a tension pneumothorax, all right? JVD, unequal sounds, tachycardia, hypoxia, right? Traumatic event. Do you know the one that everyone forgets about? Car accidents. People talk all the time, oh, you get shot, you get stabbed. If you're driving like this in your car, and I'll look into the camera here. I'm driving like this in my car, and I get in a car accident, boom. They call it the paper bag effect. People do, they hold their breath like this, they go. And then, boom, the pressure pops in pneumothorax. So you have airbags deployed in an MVA. One of the first things you want to do is listen, 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 listen. Get some lung sounds. Aneurysm, very simply, any pain from my neck to my hips could be an aneurysm. I could have a AAA down here. That's abdominal. But if we have an event where the aortic arch is being torn, or the aortic arch is being ripped, or just bulging out, that could cause chest pain, obviously. That's a life-threatening event. We don't want to just miss that. So what I tell anyone watching is, as far as aneurysm, any patient with chest pain who's hypotensive and the case doesn't make sense, that's why it's here. That's why it's here, aneurysm. So it's not one of these, chest pain, hypotensive. What if it's that, right? That's a life threat. You get a chest pain patient, think, who's your papa? And you're going to evaluate for pericarditis, ACS, pneumothorax, pulmonary embolism, aneurysm, and now you have a good look, a good presentation. These three receptors right here are some of the most important for EMS. Why? Because so many of the drugs that we give or our patients take at home act on these receptors right here. Now, first, I want to go over some key words. Now, an agonist. An agonist is a drug that binds to a receptor site. So it activates it, it turns it on. I'll write it out here. So an agonist, okay? Agonist. Okay? Now an antagonist okay? See the difference? Agonist binds to a receptor. An antagonist is going to block a receptor. So, epinephrine albuterol, that's going to be a agonist. It's going to act on, it's going to bind to that receptor site, turn it on. Low pressor, metoprolol, for example, propranolol, right? Atenolol, that is a beta blocker. It's an antagonist. To give you just a totally different idea of reference, okay? There's other receptors. Now, we're trying to talk about the alpha and beta today, but I want to give you one more example before we start the little lesson here. Is, let's say we're talking about opiates. The mu opioid receptor is a receptor in the body. So let's say you take heroin. That's an agonist to the mu opioid receptor. Narcan is an antagonist to the mu opioid receptor, thus stopping the effects. There it is, okay? Now we know that. The final piece is receptors in the body, okay? They all have different names and they all have different functions. If you understand that, you're going to understand this, which means you're going to understand the mechanism of action of drugs. Great. Well, let's start with this. Alpha 1. So if I have a drug that I put in the body, and that drug, its mechanism of action, what it does in the body, acts on alpha 1 as an agonist, I'm going to get vasoconstriction, which will then cause an increase in blood pressure. Think about this. When you're in septic shock and your body is in mass vasodilation, your blood pressure goes down. So if I vasoconstrict and I clamp down, like I'm trying to survive because I'm bleeding out and I clamp down, same deal. My BP goes up. Okay? So vasoconstriction goes up. Beta 1. So with beta 1, with that receptor, if we have a drug, it's an agonist, and we act on beta 1, it activates it, turns it on. What do we get? An increase in heart rate, but mainly we also get an increase in contractility. That's strength of the heart. Now finally, beta 2 is very simple. Beta 1, we have one heart. That's how you remember it acts on the heart. Beta 2, we have two lungs. Okay? So with two lungs, that means beta 2 is going to have to do with the lungs, right? What it's going to do is bronchodilate. It's going to open up the lungs to make you breathe better if you have something like, think about it, why we give a beta 2 agonist? Asthma, right? COPD, anaphylaxis. Remember A.A.C? Right. Okay? So this right here are the receptors you need to know. Now, before I go, what happens if I block this? If I block this? If I block this? Essentially, you get an opposite effect, right? So hear me out on this. Before I go, this is real important. If you use a beta drug, okay? Let's say I'm using albuterol. Albuterol's goal is to act on beta 2. But when I give albuterol, the beta receptors are like twins. They're like twins, okay? So kind of like conjoined twins. That makes a little more sense, okay? If I act on beta 2, I'm going to get some beta 1. That's why when you give albuterol, you get beta 2 reaction. But you also get an adverse effect of tachycardia. Okay? Think about this. If I give low pressor, metoprolol, a beta blocker, to a patient, its goal is to act on the beta 1. I want it to lower your contractility, lower your heart rate, right? But I also get some beta 2 effect. So you also go to block beta 2. So what if your patient is an asthmatic? Could that be a special consideration to not give the drug? Sure, it could be. So this is your alpha, your beta 1, and your beta 2 right here. I'll see you guys next time. First thing we're going to look at here is the word acute coronary syndrome. The only thing I want you to think about with the word acute coronary syndrome is something is happening to a coronary artery vessel in that patient's body. We don't know what. We're going to find that out in a second by doing stuff, okay? We're going to go through it, okay? But something is happening to that patient's coronary artery. So once we say, okay, that patient's having an acute coronary syndrome, well, what type of acute coronary syndrome are they having? Is it really, really bad, or is it just kind of bad? Let's talk about that. So when somebody has chest pain, we are suspecting that, man, they might have an acute coronary syndrome. So we do an EKG. The 12-lead EKG is either going to show ST elevation or no ST elevation. Now, quick side point. Some ST elevation is not an MI. Okay, so really what I'm saying here is, are they having a STEMI or is the EKG not a STEMI? Because a STEMI stands for an ST elevation. The ST segment is elevated on EKG, and that shows an MI, which is 2 friends up and 2 friends down. 2 contiguous leads up and 2 contiguous leads down, okay? So if it's not a STEMI and our patient's got chest pain, difficulty breathing, or nausea or vomiting, whatever, we do an EKG, it's normal, or it's not a STEMI, we go over here. So now what happens to our patients? They're going to end up in the hospital. They have, let's say you've put in an IV, or maybe you haven't, or whatever it is. They're going to get IVs. They're going to get blood work drawn. Okay? So now the question is, you've probably heard of stuff like cardiac markers or troponins. They draw these in the hospital. It shows the history, what's going on with the MI. Okay? Are they up? Are they normal? What are they? So here you can see, if we have that patient with chest pain, difficulty breathing, and the EKG is not a STEMI, and they run their labs, let's say they run the troponin levels, and everything comes back normal on the labs, but they have symptoms, we call that unstable angina. Okay? Now what if in the ambulance we did a 12-lead EKG? Everything's fine. 12-lead looks clean. They go to hospital, they draw their labs because they had symptoms. You treat them great. They draw the labs, boom, troponins are up. They're elevated. Now we have what's called, this is an NSTEMI, a non-ST elevation MI, which means they're having a heart attack, but the 12-lead doesn't show it. It's an NSTEMI. You with me? Okay. Now, that ends my little graph here. So the patient's going to end up, okay, they either have an unstable angina, NSTEMI, or STEMI. Okay? Now, if we get to the bottom of this, okay, remember they have to have symptoms, right? Which means when they get to this point, they're having symptoms, right, with the unstable. Now, I want to tell you something quickly. What happens, so about stable angina. What happens if I have symptoms, then I rest, or I take action, maybe take a nitro or whatever it might be, but I rest, and then I feel better. That's stable, okay? Now down here is a word you may have heard. It's called Prinz metal angina. Now what that is very simple, okay? A Prinz metal event has nothing to do with a clot. It has to do with a constriction issue. So normally if we have an MI, what happens is we get clot and plaque in here, and that causes the problem. A Prinz metal event has to do with the vessel being under stress. So for some reason, that person's coronary artery has just decided, for whatever reason, just clamp down like this. There's no plaque. There's no clot. It's just a clamp down issue. And that is what, if you have a patient who has Prinz metal angina, that's what's happening. Their coronary artery isn't blocked, it's clamped. It's like this. It's constricted. Why? Usually due to stress, for example, the stress in that vessel. Okay? So there it is. My friends, I hope I cleared this up so you understand these terms and what they are. Let's get it. I'll see you next time. Inside this video right here, I'm going to talk about the basics of EKG so you understand the landmarks and where everything is. Here we go. So this here is basically essentially your normal EKG, what it looks like, okay? Now, what I'm going to do is break down the waves first and what they are. So over here, let me just draw something for you real quick. Remember in the heart, we have the atria and the ventricles, okay? So I'm going to just do a little split up here, okay? Now we know here we have right atria, right ventricle, left, okay? So the way that the electrical conduction of the heart works, it starts up here, okay? SA node. Right here in the middle, we have the AV node. We have some internodal branches. So obviously the impulse has to travel over here and then go through here, right? And then finally here we have the bundle branches. They branch off, okay? They each get one of those, okay? Bundle of His is right there, okay, right out to the AV node. And then we have what we call Purkinje fibers down here, okay? So as I go through what the waves are, it makes sense that the waves go atria to ventricle, okay? So the first wave is the P wave. Now the P wave represents atria depolarization, D as in dog, okay? Atria depolarization. What that means, it's the atria's turn to go off. It's the atria's turn to fire in the electrical conduction, okay? That is represented by the first positive deflection on the EKG. What does that mean? What that means is this, okay? If I draw asystole, there's no positive and no negative deflections here. It's a flat line. This is a positive deflection. See how it goes up and it points up? This is a negative deflection. See it points down? This line is the isoelectric line. That's a line that says if it points up on the isoelectric line, positive, points down, negative deflection. So the P wave is the first positive deflection on EKG, and it represents the atria depolarizing. So we're representing this right here, coming down, okay? Now, here we have a Q wave, and this whole thing is the QRS complex. Okay, we call it a complex. They're on a team. They're all together. Now the Q wave is the first negative deflection on an EKG. So look, nothing going on. Ooh, a positive deflection. Nothing going on. Oh, a negative deflection. Q wave. We go up. The second positive pointing up deflection is the R wave. We keep going. And now we'll count them up. The second negative deflection is the S wave. Over here, I'm going to come back to, I just want to label it, is 1, 2, 3. The third positive deflection is a T wave. Now let's talk about what is a QRS complex. So the QRS complex, what it is, it represents the ventricles, ventricular depolarization. Depolarization, what it means, it's your turn to go. It's your turn to fire. It's your turn to activate. That's what depolarization means. So the atrias went, they fired. Now it's the ventricles' turn now it's their turn to fire, represented by the QRS complex. Now what's the T wave? The T wave, what it is, it represents ventricles, the ventricles, repolarizing. Ventricular repolarization, okay? Repolarization, R, like a rhino, R, that the ventricles are relaxed. They're back in their resting state. They already went off, they fired. Now it's time for them to relax, okay? That's what repolarization is about. So think R was in rest, relax. There it is. Now you're probably wondering, Evan, here's the atria depolarizing. There's no wave for the atrias to repolarize and rest? You're correct. The QRS complex is so large, that wave, which is not even a wave, is hidden in here. There is no wave for it. So it's P, Q, R, S, T. This is isoelectric line. Isoelectric line. Okay? There are the basics of an EKG. Hey everyone, what's going on? It's Evan again, the paramedic coach. Today we're talking about 12-lead EKGs. We're going to talk about what lead. A lead means a view of the heart. Where is it looking at in the heart? And we're going to talk about what arteries at the end are being affected by these views. We call leads views. Views are leads. So a lead shows the view of the heart. You got it? All right, here we go. Now we start here. We first got to define who are friends. In class you've heard this called contiguous leads. So first let's find who friends are. Okay, first. Now we have one AVL, they're friends. Okay, let me get a better marker. There we go. We got 2, 3 in AVF. they are friends. They make this kind of L here, okay? We have these two are friends. AVR has no friends. We're just going to cross AVR off. We don't even got to worry about it. V1 and V2 are friends. V3 and V4 are friends. V5 and V6 are friends. So now we know the contiguous leads. What's the criteria for having a heart attack? 2 friends up, 2 friends down. That's a STEMI. So 2 contiguous leads up, 2 contiguous leads down. That's a STEMI. Okay? So this is going to be your lateral wall. This is also lateral. This is going to be anterior. I'm just going to put A-N-T, anterior. This is septal. Okay, septal. And here is inferior. Okay. Okay. So we have lateral, inferior wall of the heart. So remember, inferior, what does that mean? Does that mean up or down? Down, bottom. Okay, inferior, lateral, side, anterior front, septal. Okay, right in the middle of the right and the left is the septum. Okay? AVR, no friends, don't worry about AVR. So now what I want to talk about is, okay, now we know where these leads, these views of the heart are looking. So if I say V5, where's V5 looking? The lateral wall. V1, septal. AVR, no friends, don't worry about it. 1, lateral. 2, inferior. AVF, inferior. AVL, lateral. V1, septal. See? So now we know that V1 and V2 are septal. We know that V3, V4 are anterior. But what arteries do they affect when they get blocked? I'm going to clean the board, show you that. I've now placed here the arteries, the coronary arteries, that are going to go along with the lead or the view that we talked about earlier. So first we have the circumflex. Okay? So circumflex, just think lateral. What's lateral? We just talked about it. 1, AVL, they're friends, and then V5 and V6. So circumflex gets attacked when a lateral lead gets attacked. Okay, we got that one? Let's move to the next one. Nickname is the Widowmaker. Okay? Now, here, the main culprit is V3 and V4. So if you can imagine the LAD, okay, it's descending, so it's going like this, okay? If we have a blockage at the proximal, at the top of your LAD, you may see it show up in your septal leads that it's elevated. If it's more in the middle or more down, that's where it's going to be more of a V3, V4 issue. It can even get a little bit of a lateral issue too, okay? So the big thing I want you to remember here is LAD, think V1 to V4, V3 and V4 are the main ones. Sometimes we get V1 and V2. But if you want to make it simple, LAD, V1 and V4. Just want to give you the information. The right coronary artery, you know, we always say don't give nitro in a right ventricular infarct. You know, caution nitro in inferior wall MI. Be careful with that, right? People always say that. That's how I remember it with the right coronary artery is 2-3 AVF. Because if I have an MI and 2-3 AVF, I'm thinking about the right side of the heart. I'm thinking about nitro decreasing their preload. When I talk about preload, I'm talking about the right side of the heart, right? You see? So this is where and how I remember this. Now the other thing to remember is it's 2-3 AVF plus the posterior side. So, my friends, real quick tip. If I have a posterior MI, which is not going to be a normal 12-lead EKG, you have to do an EKG on the back, where is my reciprocal leads going to be? The septum. V1 and V2. That's how you know you have a posterior. Now you know it. Think about it. If it's posterior, what's the opposite on the other side, or right on the other side of that baby? Septal. And there it is. The PERC rules. It's pulmonary embolism rule-out criteria. Let's say you have a patient. And let's say that the patient you think is having, maybe that you think they're having asthma, or CHF, or COPD, or maybe a heart attack. And you treat them for one of those things, and it looks pretty clear-cut. A few days later, you get a report back from it could be your EMS officer, whoever, and they go, hey, that patient had a bad outcome and they had a pulmonary embolism. If these are all negative, and there's 5 criteria, your patient has a less than 2% chance of a PE. Now, the other reason why I like to remember this and use this with students is because it shows you the risk factors of PE and the signs and symptoms of PE while creating great documentation for yourself to cover your butt and help your patient. It's incredible. It's the PERC rules, and here we go. Now, the first note here, if you will, is something called the Virchow's triad. So a lot of people in EMS know Cushing's triad. It means there's 3 things, and relating to whoever we're talking about. So in this case, his name is not Cushing's. It's not Beck's. It's Virchow's triad. Okay. So Virchow's triad is a triad, 3 things, okay, that put you at risk of having a PE. Now, the first one is being in a hypercoagulable state. What does that mean? Hang on. Hyper, okay, that means more than usual, more than normal. Coagulable, you're more at risk. It's more easy for you to have a clot. So if I say that woman's in a hypercoagulable state, that woman is more at risk and it's easier for her to have a clot. So what are the hypercoagulable states? Birth control, recent pregnancy, or if you're pregnant, cancer, okay? Those are some hypercoagulable states. Now, it's triad, that's part 1. Part 2. Part 2 is stasis. So what does that mean? That means long train rides, long plane rides, long bus rides. If I didn't say it yet, long car rides, bed rest. You're not moving. Stasis, you don't move. Okay? And then finally is recent surgery or a recent vessel has been damaged in your body, right? So imagine someone who would be a super high risk of a PE would be somebody, we're going to go over, that has advanced age, they have a hypercoagulable state, they also have been in a period of stasis, and they had a recent surgery on a vessel. Whoa, they're at risk of a PE, okay? Now, number 2, we're assessing our patient. We're trying to call them PERC negative if we can, so we can document it, okay? And also it helps us with the patient care as well, okay? Now, 2 is vital signs. So I always tell you, and I've probably told you here before, but I'm going to reiterate here, is pulmonary embolism, they're going to be tachycardic and they're going to be hypoxic. So if they're not and they have normal vital signs, then you put another negative there. So far, let's just say we're negative. Okay, we're trending. Age less than 50. Okay, so you have to be younger than 50 to be PERC negative. Okay, now what else? No hemostasis. Now what is it? What is that? Whoa, what does that mean? Well, hemo is blood. Okay, hemo is blood. Now, all that word means is the patient. So if I say no hemostasis, that means that, we'll go back to this woman over here. This woman right here is not coughing up blood. Same thing, it's a fancy word for it, okay? Medical terminology. But there it is. So they're not coughing up any blood. Great. Finally here, there's 2 parts to number 5. How many parts? There's 2 parts to number 5, okay? So the first part is you're going to do a leg exam. This is why I always tell my students, when anyone has difficulty breathing, you check both their legs, okay? So if the patient has swelling, signs of a DVT, which we know is the leg swelling, we know all that, okay? Pain in the leg, right? Or the second part is, do they have a history of a DVT or a PE in the past? So let's say you're taking care of a 45-year-old female patient, difficulty breathing. You assess her. Vitals are normal. She's not pregnant. She's not on birth control pills. No recent surgeries. Okay, great. I told you she's 45, so she's under 50. Okay, great. We do a leg exam on that patient, and we see no swelling in both legs, no pain in both legs, no history of DVT, no history of PE, and finally, the fourth one there is she's not coughing up any blood. Guess what? She's PERC negative. What's going on? She has less than 2% chance by this PERC rule of having a PE. You document that. You help solve your patient's problem while covering your butt with your documentation. If you don't put this in your chart, or even at least part of some of these things in your chart, then you're really, it looks like to the person reading your chart that you're not assessing for it. And if they have a bad outcome, this doesn't look good. I recommend that you follow this guide here and start putting these into your charts. Guys, hope you enjoyed this one. It's a super advanced topic, super advanced video. Hope you enjoyed it. Much love, and I will see you next time. Thanks for watching. Hey, my friends, and possibly, hopefully, some new friends watching this video. I hope that you really enjoyed this video. If you're one of these three people, if you're getting ready for EMT, advanced EMT, or paramedic school, maybe right now you are in school right now, but you're just not getting it. Maybe you're in paramedic or EMT or advanced EMT, and you're struggling. Or maybe right now you're getting ready for your national registry exams from EMT all the way to paramedic. If you're one of these three people, get my life's work, get my prep course down below in the description. I give you access to over 180 plus videos of content that will take you literally from pre-EMT all the way to your first year working on the job as a paramedic. So if you're anywhere inside of that realm, I want you to grab that prep course down below. You get access to me inside our community group, and we are in the thousands strong in our student group. My friends and my new friends, thank you so much for watching this video, and I'll see you next time. Thanks for watching.
Don't waste any time. Don't be hesitant and just do it, because I know this program works. And I know it got me to where I was, where it's been a year without school, from EMT to, hey, I passed my test in 70 questions. Like, go for it. You could do it. Like, do not hesitate and don't waste any time.
People that don't know you, they need this program. This program is not a choice. To me, this program is a have to.
I went through it. I spent the time and money in other areas, and I'm just gonna let you guys know that this was everything I was searching for the whole time. The first couple of videos I watched, what I noticed, I just immediately started connecting dots on some of these things I didn't have grasped.
Like everything that you were saying was just connecting all these links inside my brain. And I just knew right then and there, I have to have this program. I have to have all the information that he's willing to give. I need all of it.
Then 9:30 on that Thursday, and that's when I found that I had passed my National Registry Paramedic. I felt like you taught it on a level that normal people can learn it versus instructors from a college. Trust them. I would say that they need to put all their trust in you.
Results, obviously passing the exam, doing it pretty quickly, 70 questions in about an hour.
Go for it, 100%. Like me and you discussed earlier, I was early in this program when you were just getting started up, and to see the results that I got from then to how much you've upgraded now and to how much stuff has been added, I would pay $100. I would pay $150 to go back and do it and make sure that I passed my test.
Do it. I have some people in my class now that I've recommended you to them, and they have bought in the program and all that kind of stuff. They're in the group on Facebook and all that, and I just say go for it.
Went on there, and then I continued reviewing, and I did it for about a month, and it helped a lot. Like I said, even after school, and I took that test one time and I passed it.
If he can help them, then maybe he can help me. So I took that leap. I joined your website, and honestly, it's probably the best thing I've ever invested in.
$7,000 for school, plus everything else that you put into it, all the time, and all the time off work and family and everything. It's to see people fail and fail and fail and then just quit, which I know a couple of people who have. I tend to say, it doesn't hurt to have somebody right there to talk to, send a question.
I believe the return of the investment has already paid off almost immediately after getting my certification.
Well, you definitely are like how your videos are. Like, I wasn't sure how it was going to be, but you are how your videos are. So that was awesome.
Went from 120 questions, passing 2 sections near passing 1, and then I think 2 below passing, 2 70 questions passing completely.
It's so helpful. Like I can't even really describe how much it helped me throughout these last 3 weeks to get a better understanding of situations and just being confident in my skills.
If you're on the fence and you're looking for a different way to learn and absorb the content in a non-threatening way, in a caring way, then I would absolutely recommend the program.
Particular program, you have your students engaging and you have your students discussing and you have your students actually using your products. And I'm seeing time and time again students that are coming in and announcing their new certification with National Registry.
People who are getting ready for paramedic school, or if you're getting ready to go in the Navy as a corpsman or as an Army medic, you want to prepare yourself. Evan, I know you got a program that helps people prepare that way. So bottom line is, guys, you don't ever want to hear something for the first time with a bunch of other students. So if you're in a competitive learning environment, you don't want to hear about AFib for the first time where everybody else, you want to have an understanding of it before you walk in the room.
We want to help decrease failure rates for NREMT, for EMT school, for paramedic school. Watch these videos, watch this content, and believe me, you will start to understand EMS medicine. Anybody out there that wants to serve their community as an EMT or a paramedic should be able to do that, and I'm here as a paramedic coach to help you achieve that.